I am very pleased to present to you our second series of MesoTV. MesoTV is a program that was created by the Mesothelioma Applied Research Foundation in response to the need to cancel our International Symposium on Malignant Mesothelioma. We recognize that many were seeking information about treatment, the science behind malignant mesothelioma, news of the community, and information about the workings of the Mesothelioma Applied Research Foundation. This program has been made possible by our generous supporters and sponsors. Thank you so much. It is so important for us to be able to bring all this pertinent information to the community that we serve.
Dr. Raghav, thank you so much for joining us today on this newest episode of MesoTV.
Happy to join. Thank you.
Thank you. Thank you. So you've created quite a challenge for me. The discussion we're going to have today is about probably the two hardest drugs to pronounce in the field of mesothelioma. I know it's a combination of therapies. It's Bevacizumab and atezolizumab, so if you would correct my pronunciation, and then we can start in.
Yeah, the names do keep getting more and more complicated as the years pass. But yeah, the first combination drug is Bevacizumab and atezolizumab. And then, of course, the next one is easier to pronounce, M11, but we can call it M11 for short.
Perfect. Okay, great. So I understand that this trial is strictly for patients with peritoneal mesothelioma, am I correct, or is it for all solid tumors?
Yes, so this trial, when we designed this study, Mary, we've found that there is a very big knowledge gap in understanding efficacy of drugs in patients who have peritoneal mesothelioma. And clearly I don't need to educate the target audience here. We know that peritoneal mesothelioma and pleural mesothelioma are two distinct diseases from an epidemiology perspective, from the clinical challenges and presentations that these patients have, down to surgical strategies and approaches that we take towards these patients. The only thing that has been lacking in the field so far has been the approach towards systemic therapies, where we have been, borrowing from pleural mesothelioma studies, partly because of the rarity, partly because of, where these diseases are housed. But, here at MD Anderson, we have a big GI center where we have a dedicated multidisciplinary team towards treatment of peritoneal mesotheliomas. And our pleural mesothelioma is housed in thoracic medical oncology. So, recognizing our patient population, their unique needs, and the fact that these diseases could be different, even at a molecular level, we are big proponents of doing dedicated research in rare and, in this case, an ultra rare tumor. So this study was exclusively designed for peritoneal mesothelioma. There was another cohort of pleural mesothelioma on this study, but it was a separate cohort than the peritoneal mesothelioma cohort.
So now for patients with peritoneal mesothelioma for this study, are you taking all histologies, epithelial, biphasic, and sarcomatoid?
Yes, so there was no exclusion for any of these. We wanted to evaluate this in all our patients. Now, of course, the trial does reflect the distribution of what we see with regards to these histologies in the population.
And this trial was designed for patients who are either not candidates for surgery or following a surgical relapse?
Yes, so definitely not candidate for a curative intent surgery. And about 60% of our patients had some sort of cytoreductive surgery in HIPEC previously, which is consistent with what we see out in the community. And there were some patients that presented de novo with disease that was never a candidate for surgical resection.
So is there any requirement for these patients to have had the standard therapy of Olympus cisplatin, or can patients enroll directly into this trial not having had a platinum?
Right. So this was a second-line study, Mary. So patients had to have progression or intolerance to a platinum pemetrexed-based treatment. So both the drugs. Now, Avastin was not mandated, but it was also not an exclusion criteria. Or bevacizumab was not mandated or not an exclusion criteria.
Okay, good. So that's important to know. So these are two relatively new drugs, and I'm not sure that the patients that will be listening to this series are familiar with the mechanism of action and the type of drugs, because these are quite different from chemotherapy. So would you like to talk a little bit about the bevacizumab first, and then we can go into the other drug?
Sure, absolutely. And if you're okay with it, maybe I'll just try to explain both those mechanisms, sort of together. So, bevacizumab is a very common drug, and it's an older drug. This is a drug that inhibits the vascular epidermal growth factor pathway. So, this is a pathway that leads to angiogenesis or blood vessel formations that help cancer growth, right? So this drug inhibits those new blood vessel formation that helps cancer growth. And this is a drug that has been approved in many tumor types: lung cancer, colon cancer, among others. And it has shown good activity in combination with chemo. Now, there is no indication where this drug is used by itself, right? The rationale for using this drug in malignant peritoneal mesotheliomas is we know that these are vascular and VEGF high tumors. There has been a number of studies that have been done for mesotheliomas with VEGF agents, not specifically bevacizumab, but other agents that have not shown any promising incremental advantage in general. There was a study of bevacizumab here in the US that didn't show any better activity than chemo. There was a French study, the MAP study, which actually used bevacizumab in pleural mesotheliomas in first-line treatment with carboplatin. It did show some improvement in, progression-free survival and overall survival, but clearly that study was specifically for pleural mesotheliomas. Also, that study did have a maintenance bevacizumab arm. So, you got chemo with bev, and then you still got some treatment versus you got nothing. There were certain aspects of this study. So even though there is VEGF signature in mesotheliomas, let me put it this way: VEGF therapies by themselves are not uber effective in this disease, right? So they need something else to work with. Now, atezolizumab is a newer drug, and this is the same class of drugs as immunotherapy, the so-called immunotherapy drugs. Just to give people an idea of what exactly these immunotherapy drugs are. So, remember, cancers are like foreign to the body. So the immune system always wants to destroy them, right? But there are multiple ways in which the cancer avoids the immune system. And one of those ways is called the PD-1, PD-L1 pathway. So basically what the cancer cells do is they express this molecule called PD-L1, which is called program death ligand. On the immune cells, there is a receptor for these, which is called the PD-1. And normally, the reason for having that on the immune cells is, whenever you get infected, your immune system revs up, right? But you need a mechanism to decrease that immune system. Otherwise, if, after every infection, you'll start developing diseases which are called autoimmunity diseases, in which, you know, the immune system starts attacking your own body, right? So the body has developed this mechanism of this PD-1 molecule where a revved up immune system gets suppressed. But cancers exploit this mechanism by suppressing the immune system abnormally, and that's why they can grow. So, you know, a lot of drugs like pembrolizumab or nivolumab or atezolizumab in this case target this PD-1 mechanism, right? So what they do is they bind to these ligands and they don't allow that PD-1 to be activated. So in a way, you're taking the brake off the immune system and allowing that immune system to attack the cancers, right? Now, the rationale for combining these two treatments is, you know, in mesothelioma per se, we have tried, just like bevacizumab, we have tried, you know, single agent immune therapies, and the response rates are there. So there are some patients who benefit, but they're very suboptimal, you know, sub 15% response rates in most studies. And in peritoneal mesothelioma per se, the data is very limited because most of the studies have been done for pleural mesothelioma. You know, the reason why we wanted to combine these two drugs is because bevacizumab can alter the tumor microenvironment and change it from like a immune suppressive environment to a immune, you know, sensitive environment, right? So what it does is bevacizumab has been shown to increase these foreign antigen presentations on cancer cells. And when cancer cells present these antigens, and now you bring in a drug that can take the brakes off the immune system, now it's a perfect mechanism, right? You have lots of bad antigen, and then you have these immune cells that are now activated, and they can collide together to create responses. So that's the basis of the combination, and this combination is already FDA approved in treatment of liver cancer or hepatocellular cancer. So in liver cancer, same story. VEGF drugs have some activity. You know, immune inhibitors like PD-1 or PD-L1 drugs have some activity, but when you combine them together, there's a synergistic effect, right? So that was a very you know, potent combination in liver cancer, and that's why we chose to do this in peritoneal mesotheliomas.
Which was lucky for the peritoneal mesothelioma patients as well, because the toxicity and dosing had already been worked out. So you sort of had a clean slate to bring now into the clinic. So how are these drugs administered? Are these IV or are they by pill form? How do you give these drugs?
So these are IV drugs. They're given once every 3 weeks, about an hour infusion each.
And how long does this study continue? How long will you get the two drugs?
So the study was designed to continue the treatment till either toxicities arise that are unacceptable or intolerable in the patient, or till the time you progress. So there was no definite duration of this treatment. And, you know, as you can see from the results, which, you know, we'll be discussing, which were presented at ASCO this year, some patients have been on study for about 2 years, 2.5 years, pretty much the duration of the study so far.
That's great. And when they initiate this trial, so you start the drugs, and you have, you know, the 1 cycle, 2 cycles. Is it after the 2nd or the 3rd cycle that you would scan to take a look to see whether this drug is working for them?
Yeah, so after 3 cycles, so every 9 weeks. Okay. The scans are every 9 weeks, yeah.
Okay, great. And you do a regular CT scan to assess for response?
Yeah, absolutely. All the responses were according to the standard, you know, RECIST criteria, which is the standard radiographic criteria we use for any other disease mostly.
Okay. And then I guess my next question would be, what kind of toxicities have you observed and that patients should be aware of?
Right. So we treated about 20 patients of peritoneal mesotheliomas on this study, Mary, but you know, at the same time, we had also launched this rare cancer program. So there were other rare cancers that were treated with the same combination. So in totality, we had about 120 patients that we treated with this combination. And irrespective of the disease site, the safety signals were very similar. And overall, the study was very well tolerated, at least for our mesothelioma patients. Most toxicities were grade 1, grade 2. The more common grade 3 toxicities were hypertension, which is a part of the Bevacizumab drug, and some anemia, but they were seen in about 40% and 10% patients respectively. And in most cases, they were managed very easily. The anemia was not, a major hassle for treatment continuation, and neither was hypertension because you could manage it actively by antihypertensive medications. About 2 patients on the study did have an immune-mediated adverse event. Like we were talking about, once you rev up the immune system, it can have autoimmune effects. So those 2 patients did develop immune-mediated side effects for which we had to stop the treatment. But otherwise, for 18 patients, treatment was continued without any problems.
Wonderful. So what is your next plan with this trial?
So, of course, I think the first step is to make this data out and available to everyone. Peritoneal mesothelioma is a very, very rare tumor. I strongly believe that we need collaborative researchers to do larger trials in this disease. But for now, this is one of the best available evidence, that we have with regards to activity of IO or combination of IO in peritoneal mesotheliomas, right? There are some patients that get treated with, other immune checkpoint inhibitors, as has been, done for pleural mesotheliomas. I think that atezo and bevacizumab, they were perhaps the better tolerated. Of course, you can't compare 2 different trials, but if you look at it overall, I think this treatment was very well tolerated compared to other combinations of IOs that have been done in mesotheliomas. And of course, our efficacy results were, seem to be significantly better than what we've seen with other IO combinations or IOs. So I strongly, would consider use of this treatment as a part of, continuum of care. Now, that doesn't mean the work is done because, our results showed confirmed tumor responses in about 40% patients and some tumor response in about 50% of the patients. So there's still a long way to go. So all, newer trials and more rational combinations are needed. But for those that are not able to participate on clinical trials, I think this represents a very viable and safe standard of care. We have been discussing this with the NCCN guideline panel to try to actually, there is no good guidelines for peritoneal mesotheliomas either way. So we have been, discussing with them about including, guidelines for peritoneal mesotheliomas. So that patients can get the most appropriate care that's available out there, and of course we are trying to see if we can move this to a larger trial or even earlier line of setting, because frankly the outcomes in the study were much better than what we would have even expected out of first-line chemo.
Right. So I guess, that's always the problem with a rare disease, and now we have a super subset of a rare disease with peritoneal. So getting the numbers that they'll be statistically significant to move this into, an FDA approval process is going to take some work. And as you said, it's going to take quite a bit of collaboration. So, I see that as the role of the foundation to sort of insert ourselves in the middle of this and try to get everybody to the table and, advancing the therapies and really trying to get, more collaboration, more collaborative experiences among, those medical oncologists that are interested in peritoneal meso, because you really are a handful, and I don't mean a handful difficult, but a handful. There's so few of you that, it seems that, if we could get everybody to the table together again and start to discuss, what needs to be done in this disease, we can, as you said, get some standardization, which has been lacking for the 20 plus years I've been in this disease, that, we need to move forward.
Great.
So thank you for doing this trial. I know, with something with a small disease like this, it's hard to get those numbers that you need. So congratulations. I'm sure it was quite an effort. So thank you.